Good morning, everyone, and welcome. My name is Karen Jordan, and I serve on the Stanford Community Council. I want to thank you for joining us, and also thank you for coming and taking the opportunity to learn about the tremendous resources available through Stanford Medicine and all in our own backyard. It's my pleasure to introduce Dr. Frank Longo. He is the George E. and Lucy Becker Professor in Medicine. Dr. Longo chairs the Department of Neurology and Neurological Sciences, and he directs the Alzheimer's Translational Research Center. He's an acclaimed physician scientist whose work is anticipated to revolutionize therapies for patients with spinal cord injuries, ALS, and other major neurological diseases like Alzheimer's, Huntington's, and Parkinson's. Please join me in welcoming Dr. Longo.
Thank you. Well, thank you very much, Karen, and I'd like to give my welcome to everybody here on behalf of Stanford Medicine, and welcome to being in our medical school. We are in a medical school, and you are students here, so we'll put your brains to work. We'll be learning about really how the brain works, because we need to have some fundamental understanding if we want to go on and think about preserving our cognitive vitality and try not to get dementia. So we'll start off with looking at circuits in the brain. But before we do that, just to establish the big picture, the bottom line here will be strategies to maintain our cognitive vitality and to lower the odds of coming down with the dementia. This is important to all of us. For those of us planning or hoping to live to age 85, about 40%, or almost half, will come down with the dementia by age 85 if we don't have any therapeutics or a way to prevent that. So that means you or the person sitting next to you will have a dementia toward the end of your life. But we hope to come up with ways to prevent that. Another phenomena of interest to all of us is age-related cognitive impairment. So I do note that there are just a few people here over age 30, and not very many, but for anybody who's age 30 or over, you're already experiencing age-related cognitive impairment. We'll talk about that some more. And some of you may have noticed it more than others. And we have ways to deal with that too. Okay, so let's jump into the brain. So I'm showing you an image here of two neurons, these cells shown in blue, and the electrical signals through the circuitry are proceeding from left to right. The electrical signals come in to those dendrites, those fibers called dendrites, and those little beads along those dendrites are called spines. And they'll play a major role that we'll hear about several times. They're coming in on the left there, through those spines and dendrites, passing through the cell body, and then out toward the right along that axon, the output, and that axon forms a connection or a synapse on the next neuron through its dendrite and spines. And that structure, that connection is a synapse, and again we're pointing at the spine there. Electrical signal goes into that dendrite, again onto neuron number 2, and onward toward the right out that axon. And then we end up with hundreds or thousands of sets of neurons and their connections forming circuits in the brain. Our brains have about 100 billion neurons, which with each of them having anywhere from 1,000 to 10,000 connections. So we get an idea of the complexity there. But we have to understand what one spine and one synapse looks like. On the lower panels there, what we're seeing on the left is a green dendrite and some normal spines emitting from that green dendrite. On the right, we're seeing what happens to those very delicate spines as we age. We have fewer of those. And with Alzheimer's, we especially lose them in a dramatic way. And so the goal this morning is to discuss ways that we could prevent that loss of those spines, because once one loses a spine, one loses that synaptic connection. And if one loses synaptic connections, one loses memories and other cognitive functions. Now I'm showing a static picture here of those spines. And if you were medical students and I were to ask you which organ in the body moves. You tell me the heart moves, the muscles move. But those spines, over a period of minutes and hours, are extending and retracting your entire life. So these networks in your brain are highly dynamic. They're moving in your head right now. You probably didn't know that. You probably were picturing a static bunch of connections. They're moving. Why are they moving? They're reaching out with the purpose of establishing a new connection. If that connection is used, it'll become stabilized. If it's not used, it'll just retract because it has no purpose for its existence. It's a very much use it or lose it paradigm to maintain these synaptic connections. And this is happening over hours, every day. So there are a lot of things moving in your brain right now. If you're able to remember anything we're talking about over the next 30 minutes, you will have stabilized some of these synaptic connections. So that'll be our goal. Okay, so what happens in the brain when Alzheimer's disease develops? One hears about two very famous proteins or fragments of proteins, amyloid and tau. Amyloid and tau. You read any news article that's well written about Alzheimer's, it'll tell you about amyloid and tau. So we're showing a picture inside the human brain here. Those brown plaques are accumulations of amyloid. Amyloid is a fragment of a normally occurring protein called APP, and the APP protein has a job like our other proteins, and its job is not well known. It probably has something to do with stabilizing these synaptic connections. But for some reason, and no one really completely understands why, that protein is broken into a fragment called amyloid, and those fragments accumulate in clumps, and those are called amyloid plaques. Those fragments of amyloid also float around in solution, call that soluble amyloid. That amyloid is highly toxic to those spines and highly toxic to the function of those synapses. So it's accumulating. We don't know why it accumulates. Genetics might play a role. We'll talk about that a little bit. Inflammation in the brain might play a role. So for example, if a child has a concussion at age 10, sets off a little bit of low-grade inflammation, that person might be fine most of their life, but after 40 years of a little bit of inflammation, a little extra amyloid occurs. So that's the theory behind concussions making us more vulnerable to Alzheimer's disease. What about tau? Tau is a normal protein inside neurons. It forms the skeleton of the neurons. It helps them maintain their shape. And for some reason in Alzheimer's disease, that tau obtains an abnormal conformation or shape. That causes it to accumulate in clusters, and those clusters of abnormally folded tau are also toxic to the neuron. In the neuron, shown in these black cells here, the tau forms tangles inside the neuron, so what's called a tangle there. It kills that neuron, but the first thing to go is the synaptic connection, and then the entire neuron dies. These are the two main processes, in addition to inflammation, that are occurring in the Alzheimer's brain. Our job is to prevent all this, or slow it down, or reverse it. So, given this process in the brain, what are our life stages in the context of those processes? As I mentioned, starting around age 30, we begin our age-related cognitive impairment. What does that mean exactly? We divide cognition into 8 or 10 different domains. We have memory, we have language, we have visual spatial function. We have the what we call executive function. That's the ability to multitask. We have the ability to create associations and new ideas. The short-term memory is probably one of the most vulnerable areas to age-related cognitive impairment, and just speed of processing. So starting at age 30, the ability to create short-term memories starts to change just slightly, doesn't have much of a functional impact for most of us. Cognition slightly slower, but again, not a functional impact for most of us. There are certain vocations where those abilities might be important, hence certain jobs happen to have a lot of 25-year-olds and not 45-year-olds, for example. But it doesn't affect most of us. And then starting in the 60s, 70s, of course, these changes become a little more noticeable, but hopefully not functionally impactful. The good news is that some of these cognitive functions get better throughout aging into our 80s and 90s. Judgment gets better. The ability to associate past experiences to look forward in a more accurate way gets better into the 80s and 90s. Vocabulary gets better into the 80s and 90s. So it's not all hopeless. A lot of things get better as we age. And if we employ some strategies, we can also use some tricks to make that short-term memory and cognitive speed hang on better as we age, and we'll talk about those. So we have a memory disorders clinic here at Stanford, and many of our patients and families come in with some worry about their memory. It's not like it was. Is this significant or not? They may have a parent with Alzheimer's disease, sibling, they're worried about this. So they come in complaining about memory impairment. We call that subjective cognitive impairment, and we'll test them. And we have ways of testing cognition. We work with our PhD neuropsychologists. These involve 3 and 4 hour test batteries. They're quite extensive. They're testing all of these domains of cognition individually in a highly quantitative way. And what we get back for your gender, for your age, for your education, what percentile one lands in, and whether you're 2 standard deviations below the norms or not. And that's where we're concerned. So we have people that come in, their testing is normal, their day-to-day or vocational activities are intact. We call that subjective cognitive impairment. We don't know what will happen with those patients. They may go on to be, many of them will go on to be fine, but we can't rule out the possibility that they're in a very, very early stage of Alzheimer's disease. So we continue to follow them so that we know. We are working on technologies that will allow us to be more definitive about what we think about those early subjective cognitive changes. They're not quite ready for our clinics yet, but we're working on getting them there. The next stage that many people move on to, in fact, by the 65 to 75 age range, maybe up to a quarter of people are dealing with this. It's called mild cognitive impairment. This is a cognitive impairment that's greater than one expects for age, beyond what one expects for age. And so when we test those patients, they do have impaired cognition by our criteria, but their day-to-day activities are still fairly intact. So we'll give them a diagnosis of MCI or mild cognitive impairment. You'll read about this in the popular literature. That's an important diagnosis because if you get a diagnosis of MCI, over the next 5 years, one has about a 35 or 40% chance of coming down with Alzheimer's disease. That MCI will convert to a full-blown Alzheimer's disease with those odds over about a 5-year period. So it's a very serious diagnosis to get. And then finally, unfortunately, many patients will move on to an actual dementia. We define that as having impaired testing in 2 or more areas of cognition, and day-to-day activities are significantly impaired. That meets the criteria for a dementia. There are many causes of dementia. Dementia is a broad term. Alzheimer's is a specific type of dementia, and it accounts for 2/3 of all dementias. It's the most common one. It's the big one. Many people ask me, what's the difference between a dementia and Alzheimer's? Now you know. Dementia is a broad term, 30 kinds of dementias. Alzheimer's is the most common, so we'll primarily talk about Alzheimer's today. Other forms of dementia are so-called vascular dementia. A lot of small strokes can affect cognition, et cetera. A brain tumor can present as a dementia, but the common one is Alzheimer's disease. So how do we make a diagnosis of Alzheimer's in 2015? And this will be changing rapidly in the upcoming years. We take a careful history. We want to know when the cognitive signs started, what they consisted of. Were they gradual? Was the onset acute? What was the pattern? We'll do a careful physical exam, a general exam, a careful neurologic exam. As a neurologist, when I examined a patient, I'm looking for clues on etiology. If I find something on that neuro exam that doesn't fit with Alzheimer's, I'm not going to make a diagnosis of Alzheimer's, et cetera. So it's pattern recognition. We're looking for clues. My job as a neurologist is to decide whether or not a dementia is present, and if it is, what's the cause, and is it a cause that we can do something about? We'll do a careful cognitive exam. We can do a quick screening in the clinic. For example, we'll do the mini mental status exam. It's a 30-point exam. Unfortunately, some of our patients practice before they come in, but I recognize that right away when they do. 27 to 30 is a normal range, and people could score over the entire range. We'll do a brain MRI scan. I'll show you an image of that. And we'll do some blood tests. B12, thyroid, low B12 can present as a dementia. Low thyroid can present as a dementia. We never want to miss something like that. We can do something about that. The key point in having a dementia, we call it a dementia workup, is to be extremely thorough and never once miss something that can be addressed like that. So it's really important to have a completely thorough workup if dementia is a question. If we do all that in the hands of a well-trained neurologist, we're about 85% accurate. That's not good enough for a disease of this implication, right? So we're working on developing, particularly here at Stanford, better brain imaging and blood tests to get that accuracy up to 99.9% where it should be. And I'll share some of those with you. So this is some of the typical pencil and paper tests that we still do. This is not all automated. This patient was asked to, this is a typical test. We start with a blank piece of paper. We ask the patient to draw a clock, put the numbers in, put the hands in, and make it say 2:45. And a person with normal cognition can do this quite readily. This patient came back every 6 to 12 months and was asked the same question. And you can see what happened over the ensuing 5 or 6 years. We get this progressive deterioration of visual spatial ability until finally the patient really didn't understand the command, but made an attempt there. And this is a typical decline that we see. It's always heart-wrenching to follow our patients. This is a disease where the chance of it reversing is 0. 100% of the time, if the diagnosis is accurate, it will get worse. So we're up against a big one here, but we are making progress. So if you went and got an MRI scan today, this is what it would look like. It's a perfectly good MRI scan, sliced through the head, eyeballs in front, back of the brain to the lower part of the screen there. Is this MRI scan telling us whether the patient has Alzheimer's or not? No. It's telling us nothing about Alzheimer's. Why are we ordering it? We're looking for a brain tumor. It's telling us there's no brain tumor there, at least not that we can see, because a tumor can press on certain parts of the brain and cause cognitive impairment. It's telling us the patient doesn't have normal pressure hydrocephalus, too much fluid accumulating on the brain, that can present as a dementia. It's telling us the patient didn't have a series of small strokes we didn't know about, so-called vascular dementia. It's ruling out things, so to speak, but it can't detect Alzheimer's disease per se. That's been a big challenge in the field, and I'll show you how we're breaking through that challenge. Here are some examples. So on the top row there, we have an Alzheimer's patient. On the bottom row, we have an age-matched normal patient. On the left is the MRI scan again. No difference between the Alzheimer's patient and normal patient. You'll hear people say, I got my MRI scan, I don't have Alzheimer's. That's not an educated statement, right? 2 kinds of PET scans are being developed. I'll start with the amyloid PET scan, showing on the far right there. A PET scan is when a compound is made that's injected in the vein, gets in the brain, and sticks to something, and that compound has a radioactive component to it. So the scanner can detect radiation, and that's what's lighting up in bright colors. So compounds have been made that bind to that amyloid that's accumulating in the brain. So if a person has amyloid in the brain, it'll light up on the PET scan, as we see here on the far right. Notice the normal person has a little bit of signal of amyloid, and so that can be confusing in some cases. The big problem with the amyloid PET scan is that amyloid gradually accumulates in our brain with age. It's not entirely understood. And if I took 100 70-year-olds with normal cognition, 30% of them would have an amyloid positive PET scan. So if we order this, we can create a lot of confusion. Now that normal 70-year-old with amyloid in the brain, what does that mean? Is that just a normal part of aging? Maybe, but what we worry about and what the field doesn't know yet because the scan hasn't been around long enough, that 70-year-old with amyloid in his or her brain is probably more likely to develop Alzheimer's if they live long enough after age 70. That's what we worry about. We don't have the answer to that yet. The other kind of more recent, the amyloid PET scan was approved by the FDA 2 years ago. The Medicare will not pay for it yet because they feel that it doesn't affect therapy. We don't have a drug yet, there are trials going on now, that will pull that amyloid out of the brain. So this scan costs $3,000 or $4,000, and Medicare is saying, we won't pay for that because it doesn't affect care. So we do offer that at Stanford, but people have to pay for it themselves. And so it's not obtained often, but we do have it available. There are certain circumstances where we do like to see an amyloid PET scan. They're typically in early onset Alzheimer's. If somebody's in their 50s, presents with what looks like Alzheimer's, but at age 50, a lot of other things can cause dementia, we'll often get an amyloid PET scan. The tau PET scan, same idea. It's detecting that abnormally folded version of tau that occurs in Alzheimer's disease. Again, lights up in bright colors if we have it. This might be a little more accurate than the amyloid in terms of it'll be less likely, hopefully, that a normal person will have tau lighting up. Not FDA approved yet, still a big research area, probably a couple, 2 or 3 years before we can use tau PET scanning. The problem with what I just showed you is that neither one of these PET scan modalities are saying anything about the function of the brain. They're just telling us something's accumulating there. The dream of every neurologist, psychiatrist, and neurosurgeon is to have some kind of scan that will tell us how these circuits are functioning. That's what's been a dream for decades. And one of my colleagues here at Stanford, Mike Gracious, may have cracked the barrier for that dream. This is called a resting state functional MRI scan. It's a way of doing MRI imaging with advanced processing of the data done in a way that circuitry in the brain lights up. So on your left-hand side there, the orange area is lighting up circuits that are going in and out of the hippocampus. And the hippocampus is part of the brain that's vital for memory. It's incredibly sensitive as we age, and it deteriorates often first in Alzheimer's disease. We see the healthy elderly person on the left. We can easily see these orange circuits. The early Alzheimer's patient on the right, the circuits are almost gone. This is a living person in a scanner. We're getting some imaging input regarding his circuit function. This is not available in our clinic. The accuracy has to be improved, the resolution has to be improved, but we've cracked the barrier of looking inside a living human's brain and seeing something about circuitry. Mike Gracious has a paper coming out in Science, a very prominent journal, soon, where he's identified dozens of circuits in the brain, and he's made a connection to individual genetic variation on how those circuits are arrayed. So we'll be combining DNA and advanced brain imaging to really understand the status of our patients' brains. So in the near future, I hope, we will be customizing this to each one of us as an individual. We'll be looking at our genetics, and we'll talk a little bit about genetics shortly. We'll be doing blood tests that look at many hundreds of proteins in the blood, especially those relevant to the immune system. We will be looking at molecular and circuitry brain scans, and for each individual, put all this together and come up with a custom plan to, number one, predict if and when they'll start developing their Alzheimer's, and exactly which preventative strategy will work best for them, because everybody's mechanisms will be slightly different. So for example, right now, it's recommended at age 50 we get a colonoscopy. Given your genetic background, we will have a recommendation for you when you get the scan, when you get the blood test, how we'll monitor you, and how we'll prevent you from getting dementia in the first place. So that's where we're heading to. I can't tell you exactly when we get there, but that's where we should be at. What are some of the dementia risk factors? Genetics, we'll talk about that. Lack of physical exercise, so-called Western diet, medical conditions like hypertension and diabetes make Alzheimer's more likely. Lack of sleep, we'll show some images on that. And more recently, people are seeing that the old-fashioned anticholinergic medications for bladder issues raise some risk for dementia. The newer bladder medications probably don't. Okay, let's look at genetics. Most Alzheimer's, 98% of it is what we call sporadic, meaning it can occur to any of us in any family, late onset, after age 65. 2% of Alzheimer's is what we call early onset familial. This means there's a gene in the family. If a parent has it, each child's at 50% risk of getting it. It generally starts in the 40s and 50s. So if you have Alzheimer's in your family, that's your first question. When did the symptoms start? After age 65, which is generally 98% of the time, or in the 40s and 50s. And if it's in the 40s and 50s, we worry about one of these genes. Many of you may have read the book or seen the movie Still Alice, right? So her symptoms started at about age 50. So she was in the 2% category here. She had familial Alzheimer's, and she had a mutation in the presenilin-1 gene, which we can test for, but we generally don't test it in the late onset, more routine cases. The gene that primarily affects this late onset, 98% sporadic Alzheimer's disease is called the ApoE gene. This gene encodes a protein that's responsible for shuttling cholesterol around the body to the various organs, including the brain. This gene comes in 3 different forms, E2, E3, and E4. Those of us with the E4 version, and we each have 2 copies of most of our genes, so we have 2 versions of each. Those of us that have 1 or 2 copies of the E4 are at much higher risk of coming down with Alzheimer's disease. It's thought that that E4 version helps amyloid accumulate in the brain. So if one has no family history, your lifetime risk is about 15% if you live a normal lifespan. If you don't have E4, you're down to 9%. If one has an E4, you're up to 30% from 15%. Now, what if one of your parents has Alzheimer's disease? If you have no E4, say you're a 3-3, you're up to 30% risk. So just having a parent with Alzheimer's doubled your risk of getting Alzheimer's disease. You went from 15 to 30%. If you're unlucky enough to have a parent and an E4 version of this, your risk is up to 45%. And if both copies of your ApoE genes are E4 and one has a parent, that individual is up to a 60% risk, so a very high risk for getting Alzheimer's disease. So what are our preventative strategies? And by the way, the ApoE testing used to be available on 23andMe. Many of you are familiar with that. You spit in the tube, mail it in, look on the website. You learn about 250 or 300 of your genes. ApoE is on that list, but the FDA shut them down about 2 years ago. But we can test that in our clinics. We rarely order ApoE on patients. I would caution people about having an ApoE4 on your medical record in terms of insurance and other issues, and we can talk about that later. Okay, how do we prevent this? What are the strategies? We're seeing a lot recently about cognitive exercise, lumosity, et cetera. Exercise the brain, right? And the modern version of the crossword puzzle, brain exercises, right? We can think about a Mediterranean diet or nutraceuticals, thousands of websites and articles on those. We can think about our sleep, and we can think about physical exercise. By the end of this, I hope all of you will know which one of these is the most powerful and which ones have the best data. Okay, let's look at cognitive exercise. The big controversy and question with cognitive exercise is that we know if you sit in front of a computer and do a given task, you'll get better at that task. And if you're starting to develop a little bit of cognitive impairment, you'll get better at that particular task. The big question has been, does that computer exercise, do the effects of that transfer is the key point, is there transference to other cognitive functions? Would it have a broad brain effect to help delay the onset of cognitive impairment? And so Adam Ghazali and his group up at UCSF did this study to address that recently, and is probably the first well-controlled study to address this issue. So they took volunteers, divided them into 3 groups. The first group did a single task. They sat in front of a computer and kept this car on the road. The second group did a different single task. They responded to these symbols. These symbols commanded them to press a button, move a lever, et cetera. And they had to focus on following that command, but one single task. The third group had the hardest job. They had to multitask. They had to keep that car on the road while they were following the commands that these symbols were indicating. Much harder task. They had them perform these exercises. several times a week. And then 6 months later, they came back, and what they measured was that these subjects, the ones in the multitask group only, had improvement in working memory and vigilance. So they had improvement in 2 cognitive domains that they weren't practicing on the computer. In other words, there was some transference from this multitasking of keeping the car on the road and following the symbols to other cognitive tasks. So this was the first evidence that there's some broadening of effect, but it's only one study so far. So it's very early days, and the effects of cognitive exercise remain quite controversial. In fact, there was a meeting here at Stanford recently. A whole group of scientists, 69 of them, came together to make a statement. This is the statement they made, because this is a big industry, brain training. Scientific evidence does not support the brain game claims, Stanford scholars say. 69 scientists at Stanford University and other institutions issued a statement that the scientific track record does not support the claims that so-called brain games actually help older adults boost their mental powers. We object to the claim that brain games offer consumers a scientifically grounded avenue to reduce or reverse cognitive decline when there is no compelling scientific evidence to date that they do. So that's where we are in 2015. I think there will be certain patients and certain strategies where these games might be helpful. So I don't think the door is closed on these, but I wanted you to have an update of what a large number of cognitive scientists are thinking about right now. What about diet and supplements? Well, I'll share a little literature. Mediterranean diet probably overall can reduce risk of coming down with the dementia by 15 to 25%. Many of my patients ask me about coconut oil, coconut water, etc. There's no reliable data. Many ask about the omega-3 fatty acids, fish oil. No overall effect in Alzheimer's. Vitamin E, common question. That's been all over the map. A study came out in the late 80s showing a possibility of a beneficial effect. Then studies came out that there was no effect. Then a study came out showing that people on vitamin E have a 10% higher death rate than people who aren't on it. And I had one patient ask me why I was killing him with vitamin E. And then about a year ago, this was in the news, a study found a 19% reduction in the rate of decline of activities of daily living, ADLs, on people taking 2,000 units a day. However, big caveat, no cognitive effects from the vitamin E. So most neurologists, most experts think that vitamin E is not much benefit. Vitamin D, very interesting. A lot of attention recently in all fields of medicine, not just brain problems. And this recent study found that people that have a very low level of vitamin D, less than 25 nanomolar, which is pretty low, had a 2.2 times increased risk for dementia. Those that had under 50, which technically is in the normal range, your doctor will tell you it's normal if it's 50, had a 1.5 increased risk of dementia. This is just an association study. It's not a cause and effect, but it makes me prefer not to have a low D. I'm not sure there's much harm with a reasonable 1,000 or 2,000 units of D per day, D3. And then finally, turmeric or curcumin. It's been cited for a long time that people in India get less dementia. And I was always wondering, is that an urban myth or not? I'd heard it so many times, maybe just everyone thinks it's true. So I spent days looking for articles on this. I finally found one little study, a small study based on one little village in India, in a country of 1 billion people. That's it. That's not very reliable data for me. Anyway, a group at UCLA that's been really passionate about curcumin did a trial in Alzheimer's patients and unfortunately found no effect whatsoever. And these supplements are sometimes theoretically, potentially a double-edged sword. You can say, well, they do no harm. Maybe not always. Here's a study, there have been 4 or 5 studies now showing that men that take extra omega-3 fatty acids had a 40% increased risk of prostate cancer. So these aren't always free rides, and several groups have replicated this now. So again, it probably comes down to the individual, their history, their family history, their genetics, et cetera, Doesn't mean omega-3 fatty acids are dangerous for everybody, but it's just a cautionary note. Just because something's available as a nutraceutical, I don't think necessarily means it's safe. I want to see some good evidence that it's safe and it actually does something, and 99.9% of the time, we don't have that data. So I reviewed the entire literature on Mediterranean diet and probably 1,000 websites on this, and I'm going to summarize this whole thing here for you. It's probably about a 20% risk reduction in getting a dementia as far as we can tell right now. The limitation of studying Mediterranean diet is that we can't do a prospective study. Those are the most accurate studies. This data comes from association studies where we just follow people and what kind of food they eat. And the people on Mediterranean diets, there's an association between being on a Mediterranean diet and being less likely to get a dementia. That doesn't prove cause and effect. How do we get to cause and effect? We want a prospective controlled trial. Those are hard to do. So if we wanted to do that, I would take this half of the room. Let's say, for the next 3 years, you need to go to Burger King and McDonald's 4 days a week, eat lots of hamburgers, and come back in 3 years, and we'll test you. This half of the room, you stick to a Mediterranean diet and make sure you're fully adherent to it. And don't make any mistakes. And come back in 3 years. Now, could you imagine, no one's been able to do a trial like that. But that's really the only way we'd really be able to figure this out. What about exercise? Here is a prospective trial. They took a bunch of people, I think it was age 65 and above, that have only age-related cognition, not a dementia. And they divided them up into 2 groups. One had to walk 40 minutes a day. They started at 10 minutes a day, and they gradually built up to 40 minutes a day. This was going to go on for a year. The other group had the same trainer, same everything, and they did some stretching and toning, right? A little less exertion. And then they did MRI scans to measure the size of the hippocampus, shown in yellow, that delicate part that degenerates in Alzheimer's disease. Now, as we age, our hippocampus shrinks by 1 or 2% per year. And you're probably saying, that's not very much. You add that up year after year. You'd rather not have that shrinkage, right? So the hypothesis here was that, and that red line is showing the loss of volume over the 1 year period. The hypothesis here was that the walkers would have a reduced rate of decline of hippocampal volume. Let's see if we can reduce that rate of decline. Here was the big surprise. The hippocampi got larger in the people that were walking. They didn't reduce the rate of decline. They reversed it. It got larger, as if they were 20 years younger. This is from 1 year of walking 5 days a week. That's a powerful, powerful effect. Now, if you were to come to my clinic at Stanford and you had a little bit of age-related forgetfulness, and if I said, I have a drug, I have a treatment, it can actually reverse age-related effects on your brain, I think you'd be pretty interested. And I'd say, it's powerful. You'd say, well, okay, I want to hear about it anyway. And I would warn you that all powerful drugs have side effects. There's no free ride. And I'd have to tell you the side effects. Here they are. Less hypertension, less diabetes, and less depression. Those would be the side effects of this treatment. So we do have very powerful treatments, but some people don't take them. Now, some people can't. Not everyone can walk. But if you can walk safely, you have an incredible gift, if you can walk safely. Okay, we're born with our genetics, and I've always been told you can't change your genes. So we talked about the ApoE4, the E4 being a very high risk. It causes amyloid to accumulate in the brain. So this study looked at people that don't have the E4, E4 minus, and they divided them up into non-exercisers and exercisers. And because they didn't have the E4, they both had fairly low amyloid levels. But then they looked at the people that had the E4, the high-risk ApoE gene that contributes to amyloid accumulation. As expected, in the non-exercisers, high levels of amyloid. But look what happened in the exercisers that have this bad gene. Where's the amyloid? In this one study, we'll have to see more studies, exercising overcame entirely this very powerful high-risk gene. And again, this is modest exercise, 30 minutes a day, 5 days a week. We're not talking about running marathons here. So to sum up, many, many exercise papers, including prospective randomized trials, the best kind, we're talking about a 40% reduced risk of getting to dementia. The computer games, the Mediterranean diet doesn't even come close to that. Here's a trial done at people that already have mild cognitive impairment, a precursor to Alzheimer's in many people, done with women in their 70s. They were put on a 6-month prospective trial. The control group did some easy balance and toning. The other group did some intense resistance exercise, only 2 days a week. And what happened? The people that did the intense resistance training improved executive function, the ability to multitask, and improve associative memory function. These are in women with mild cognitive impairment. Again, a very powerful drug effect. We don't have a drug that works this well yet. And if we look at all the exercise randomized controlled trials, there is a significant positive effect of exercise that one can see in the literature. What about sleep? My colleague Christine Yaffe up at UCSF has studied this quite a bit. People that have sleep disordered breathing, apnea during sleep, are almost twofold more likely to get a dementia. So we worry about our patients and their sleep. We often send them to the Stanford Sleep Center for assessment. And what happens during sleep? This graph is showing amyloid levels in the spinal fluid during the night and in the morning, and that blue shaded area is during the night. One group in the upper line there, they were interrupted every 2 hours during their sleep. They were forced to have a terrible interrupted sleep. And then the red arrow is pointing at the group that they were interrupted because their spinal fluid was being sampled for amyloid levels, right? It's a heck of an interruption. The other group were allowed to sleep, but then in the morning when they woke up, their spinal fluid was examined. The people that had the uninterrupted sleep had this morning decrease of amyloid. So the theory is that with a good sleep, we're clearing some amyloid out of the brain every night. And this might be one reason why sleep is important. We don't know entirely yet, but it's very interesting. Here we're looking at incidence of Alzheimer's over time in people that have either poor, average, or good sleep. Of course, the E4 people, the ApoE4 people are going to get more Alzheimer's over time, but we can see the Alzheimer's incidence goes down as sleep improves, even in the people that have the E4 high-risk gene. And if we look at amyloid accumulation in the PET scans, the people with less than 6 hours of sleep, more amyloids accumulating. People with greater than 7 hours of sleep, less amyloids accumulating. So to summarize all this, we have physical exercise, a lot of good trials, we need more, 40% risk reduction. Diet, we don't have the prospective best kind of studies, but maybe from associative studies, 20% risk reduction. Sleep, maybe a 25% increased risk, up to 50% if we don't sleep well. And cognitive exercise, almost no data showing any kind of benefit at all. What my patients are interested in, my families, are almost the reverse. They love the idea of sitting at a computer. They love going to GNC and finding the best nutraceutical. But when it comes time to talking about walking every day for 30 minutes, that's not a favorite topic. So it's funny how it's the reverse of what the data is telling us. FDA Approved Therapies, you've heard of many of these drugs. These boost the neurotransmitters a little bit in the synapse. We put our patients on these. They can help memory a little bit for the first year or two after we diagnose them, but they're not slowing down the loss of the synapses. Unfortunately, these drugs don't slow down the degeneration, and that's what we're working on developing. In terms of the news that you're hearing now, some of these efforts include creating antibodies that bind to these clumps of amyloid and remove the amyloid from the brain. We've had some failures in that approach, but there was one announced in March, this past March, where there's some early success. We'll see how that plays out. It'll be another 2 or 3 years before we fully understand that. Goal is removing amyloid. This is a study we've done at Stanford, and I'll wrap up. My colleague, Tony Weiss-Korig, and joined with my group here at Stanford. This is a study where the blood supply of young mice, shown in white, is shared with the blood supply of an old mouse, shown in gray. The old mice, as we know, typically lose these synaptic spines, and show the spines on that left panel there, we see that dendrite with lost spines. The old mice that got the young blood regrew their spines, shown in that right panel there. There's something special about that young blood. And in fact, we can test memory in mice. We put them in this little box, ring a buzzer, give them a little gentle shock. A normal mouse and a young mouse will learn pretty quickly. You hear that buzzer, shock's coming, they'll freeze, right? The older mouse, the Alzheimer mouse, they'll hear the buzzer, they won't freeze because they couldn't remember. The memory was normalized in the old mouse given the young blood. There's something special about that young blood. So we've started a trial here at Stanford this past October. It's gotten worldwide attention. We're giving young blood to Alzheimer's patients at Stanford. It's a trial. We'll see what happens, but we're trying to reverse those lost spines. My own group is creating a molecule that in Alzheimer's mice is capable of reversing the loss of dendrites and spine. Normal mouse on the left, Alzheimer's mouse in the middle. That neuron is losing its dendrites, losing its spines. We give that mouse our drug, reverses that loss. And if we can accomplish this in a person, if they're in a nursing home, they'd get sent home. That's the problem we hope to create with this drug. So, for those of you who've been down Quarry Road lately, seen some construction there across from the shopping center, this will be a 5-floor, brand new neurology, neurosurgery, neuroscience outpatient center. We'll have a major Alzheimer's program here. The goal will be to promote brain health every which way we can. The perfect clinic would have a gym in it, but we don't have enough room. We don't have enough room for that. But we are developing better ways of imaging the brain so we can detect these changes early, because we just need to prevent this, but I still would like to reverse it in my patients that do have Alzheimer's, and we're creating more potent therapies. So I'll wrap up there and I think we have about 10 minutes for questions, something like that. So thank you. Yes. Yeah, the question is social exercise versus solitary exercise. I'm not aware of any of the exercise studies that have controlled for that, but that raises a really important point. I basically review this as sort of a siloed way, one intervention at a time. I do think, though, although there's not much evidence of that, we need to combine things. So probably you need to do everything: exercise, socialize, and have a reasonable diet. But that hasn't formally been done. Yes?
I've read a couple of studies from Mount Sinai Hospital where they said that people who've been on anti-cholesterol medication for at least 10 years or maybe more had a lower incidence of
Alzheimer's. Yeah. Yeah, the question is, work at Mount Sinai that I am familiar with, people that have been on the statins, the cholesterol-lowering drugs, for a number of years are having lower rates of Alzheimer's. Statins have been of an interest for a while, and that's a great example of what we call an association study. We'll take people that got Alzheimer's and those that didn't, and we'll compare the medications they've been on. So it's been a very interesting association study. Unfortunately, when the prospective, moving forward trials have been done, at least so far with the statins, the cholesterol-lowering medications, they had no effect on Alzheimer's. So it just shows, one, the importance of the prospective trials. I'd say about 99% of what we read in the news, which is really exciting, is based on associative trials. And so it's an okay start, but as an intelligent group, you need to immediately, when you see something in the news, is this association? It almost always is. It's okay. It's fun. But when you see a prospective randomized controlled trial, that's gold. It's expensive. It's time-consuming, but those are the ones to pay attention to.
I just have a short question.
Yeah.
This presentation you gave, is it available online?
Is on.
I'll have to ask the bosses here if it's going to be online. I don't know. We'll see if we can do that. But thank you.
Hello.
I'm going to try to go with who's in order. So, yeah.
I just have a quick question.
Yeah.
So the benefit of exercise, is that related to a higher heart rate or
Oh, thank you for asking that.
weightlifting? What?
Yeah, how much exercise, higher heart rate, what? Okay, basically these studies generally involve modest exercise. What is modest exercise, right? It is some degree of exertion. Here's some rules of thumb. The strictest would be, if you want to bother taking your heart rate, would be about 65% of your predicted maximum heart rate for your age. So you can find online a little formula that one plugs their age into and calculates your predicted for your age and gender maximum heart rate, and then 65% of that would be considered a modest exertion, a good exertion level. That's probably the most precise way to do it. Easier rules of thumb would be, if whatever you're doing in a reasonable temperature like this, you'd start to sweat in about 10 minutes, one rule of thumb. And the third rule of thumb is, while you're doing this, for example, a brisk walk, you wouldn't feel comfortable speaking in complete sentences if you were walking with somebody. So there's some helpful guidelines on moderately brisk exercise, and that's what these studies focus on. Many of these studies are less than 5 days a week, but the CDC, American Heart Association, American Cancer Society recommend 30 minutes, 5 days a week, same for the brain. I would do 5 to be safe, but maybe 3 days is good enough. We don't really know the doses. Yeah. Who was next? I need help on knowing who was next. Right there, okay.
Doctor, excellent talk. Last 10, 15 years in the Western world, there are a lot of yoga and meditation centers are propping up. Is any study done which will help this thing?
What kind of centers?
Yoga and meditation.
Oh, yoga and meditation, yes. There aren't very many. I'm open to any effect having being beneficial. I haven't seen much in the way of formal studies on yoga and meditation. High levels of stress can damage the hippocampus. We do know that, so it would make sense that lowering stress could be beneficial. One of my colleagues here in Stanford Neurology, Victor Henderson, did a Tai Chi prospective trial, and I think he found some effects with that. Possibly beneficial, not as much study yet. I wouldn't be mutually exclusive. If I did yoga or meditation, I think that might be helpful. Then I'd probably go do my aerobic exercise too. So I don't know. There might be some I need help with, because I want to go in rough order. Over here? Over here, okay.
Hi, thank you for your talk. I'm wondering if there's any evidence between a connection of bipolar 1 disorder and an increased risk of dementia?
Yeah, evidence for connection of bipolar 1 disorder and increased risk of dementia. Not that I know of. For almost all of the various psychiatric disorders that often occur early in life, we wonder about later in life will dementia occur, and I don't know of any higher risk. In fact, many of these disorders, like autism, et cetera, some are a problem of too many synapses, because we're born with more than we need and we prune them, and some of these disorders involve not enough pruning and there are too many. Yeah. Where, over here? Okay.
As I age and my friends age, we find that we don't sleep as well.
Right.
And some of us take sleeping pills. And I wonder if you could comment on how urgent is it that you get, like 8 hours? What can be done if you don't? Not everybody can come to Stanford Sleep Center.
Right, right. So the question is, of course, as we get older, sleep becomes more difficult. I wouldn't stress about it. I mean, hopefully, 8 is a high bar. 8 is a high bar to set, right? I think I would feel pretty good about a good 6 or 7. I think the stress makes it more difficult. I get asked frequently if sleep medications raise rates of dementia. I haven't seen any data on that. If somebody's in early phases of dementia, sleep medications can make them more confused. But I don't have any easy answer to that. I know people that physically exercise, get better sleep. I do know that. Yeah. This gentleman back there that I met earlier, yes.
For people that have had difficulty adopting this healthy lifestyle, exercising, monitoring diet, what's the good strategies for them to successfully make this sustainable lifestyle?
Yeah, strategies for exercising and watching your diet. We need better ones. I mean, I'm fascinated by the digital health revolution, and I'm hoping these will help us. What I want to see, when I see my patients, I spend 15 minutes with them trying to figure out, well, a lot of times they're afraid to come back and see me because I told them to exercise. They know the first question I'm going to ask them, right? But I want to be able to see on my computer screen, the Fitbit's just a beginning, but those types of devices, I want to see what they're doing with an instant look so we can have a nice discussion about it. I'm hoping that will help, a continuous monitoring. And I think, for my patients who can walk, and especially the worried people that are worried about their memory, and they're otherwise healthy, and then I ask them, okay, I appreciate your concern about the memory. We talk about it. I do a careful exam. I say, tell me about your exercise. None. And I'd say, well, I'm going to educate you, but you're coming to me with concern about memory and you're doing no exercise, even though you're able. That'd be like somebody smoking and coming to me worried about their cough, right? Your brain will deteriorate without exercise. So we need better technologies to make it doable. It's hard for all of us. I can't stick to a Mediterranean diet. I wish I could. Yes?
You are recommending a moderate level of exercise, 65% of maximum heart rate.
Right.
Is there any benefit for a heavier duty exercise or a greater frequency of exercise?
Yeah. Is there any benefit for a higher than 65% or greater frequency? No data on that. I kind of doubt it. I think it probably is a flattening curve, so I doubt that there is. I'm going to go in order. Somebody over here, yes.
Regenerative medicine.
Regenerative medicine.
Genetic engineering, those kinds of things. Is there any promise in your opinion? And if so, is there a schedule, you think?
Right. So in terms of regenerative medicine, the technology of stem cells is what comes up quite a bit. And the problem in Alzheimer's, at least in the early to mid stages, is not so much a loss of cells, it's the loss of these spines and these synaptic connections. And adding a stem cell won't fix that. We need to prevent that synaptic loss. So I think really the drug strategies that we're developing will be more effective than, say, a stem cell approach. And that's one regenerative approach. Now, if somebody's in late stages, perhaps it could be helpful. But I think that's further off.
This blood transfusions that you talked about from the young to the old, how often would you have to do it?
Yeah.
When do you see the benefit?
Yeah. I wish, how often do we need to do these blood transfusions? I wish it were just one time and they're available out there in the lobby. But it's an involved trial. It's about 4 months and it's at least 12 or 14 visits. We've had people from all over the country willing to fly in, but unless a person's in the Bay Area, it's not practical. It's quite a commitment. It's many visits for being studied and cognitive measurements, visits beyond just getting the transfusion. And if somebody's not 100% committed to those analyses, we can't allow them to be in the trial. The mice, the mice had a continuous blood flow of young blood. But we can't do that with humans. So, the humans is every few weeks. Yeah. I think we're at the last question, but I can be available later out in the lobby. Yes.
How do you choose people for trial?
How do we choose people for trials? Every trial has what we call inclusion criteria. So what stage we want. For this particular trial, we're doing mild to moderate Alzheimer's. We unfortunately have people that are too advanced to be in the trial. What medical conditions they have. If they're pretty sick from other things, they can't be in the trial. It's too risky. And the big part is having a supportive family and that they're going to show up for every single time. Those are inclusion criteria. Pardon me? I'm not sure, but if you check the Stanford Memory Disorders Center website, we try to list our trials on it. We have multiple trials. I think we're out of time, right? Okay, thank you. Thank you.
So thank you, Dr. Longo, and thank you all again for coming. Just so you know, this talk will be available on podcast.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.